Welcome and thanks for joining. This is Richelle Marting, and it's that time of year when we start to get a glimpse into changes that Medicare is considering for the upcoming year's physician fee schedule. This year's proposed rule was just released, and I'm looking forward to sharing the highlights of what you can expect in the final rule. The proposed rule covers a range of topics this year. As expected, telehealth is a focus area, and in particular, timelines for the coverage of services that have been added to the telehealth list during the public health emergency that are actually different than what was proposed or finalized last year in the fee schedule for those telehealth services. Medicare proposes to codify several provisions related to split shared visits and teaching physician services into the regulations, where those rules previously were only housed in Medicare manuals. And we even see some changes to those rules from their previous form that we had been used to when they were within the Medicare manuals. Medicare gives guidance on how to determine when therapy services for PT and OT services should be billed under the therapy assistant, closes the patient financial responsibility gap for colorectal cancer screening services, creates several new flexibilities and payment improvements for rural health clinics and FQHCs, and discusses how the concept of virtual presence that was new to the public health emergency will apply as the public health emergency ends. Now, the proposed rule in its current form is over 1,700 pages, so I'll do my best to consolidate that to the high points and the key points that you need to know, starting with telehealth. Every year, Medicare allows individuals to submit requests to add services to the list of covered telehealth services. And there are two categories, two ways that a service can be covered as telehealth under Medicare. And historically, that had been Category 1 and Category 2. Category 1 telehealth services are those that are similar to professional consultations, office visits, office psychiatry services that are already on the Medicare list. So any service that an individual or group requests be added to the telehealth list, Medicare will evaluate whether the requested service is similar to any other service that's already on the telehealth list. And in reviewing those requests, Medicare's looking for similarities in the roles and the interactions among the patient, the practitioner at the distant site, the telepresenter if there is one, any practitioner who's present with the beneficiary at the originating site. And Medicare is also looking for similarities in the types of telecommunication systems that would be used to deliver the service. So for example, the use of interactive audio-visual two-way real-time telecommunications technology. The other way that services are typically added to the Medicare telehealth list each year is Category 2. And Category 2 telehealth services are not necessarily similar to anything that's already on the current Medicare telehealth list, but Medicare would review a request to add a service to be covered as telehealth as a Category 2 service by assessing whether that service is accurately described by the code when it is furnished via telehealth, and whether the use of a telecommunications system to furnish that service produces demonstrated clinical benefit to the patient. So anybody requesting that a service be added to the telehealth list as a Category 2 service, because it's not really similar to anything else that's already on the list, but the requester believes it's appropriate, the code used to report it continues to describe the service even when it's delivered via telehealth, those requests should include evidence on any relevant clinical studies that demonstrate that the service furnished via telehealth to an individual improves the diagnosis or treatment of an illness or injury, or improves the functioning of a malformed body part, including dates, findings, a list of copies of published peer review articles relevant to that service. Medicare's evidentiary standard of clinical benefit does not include minor or incidental benefits. What they're looking for is the ability to diagnose a condition without access to an in-person diagnostic service, treatment options, decreased rate of subsequent diagnostic therapeutic interventions, and so on. So those are the ways that telehealth services are normally added to the list. This year, Medicare did not receive any requests for telehealth services to be added as Category 1 or Category 2 by the deadline to submit those requests. And so there would, under this proposal, there would be no new Category 1 or Category 2 telehealth services beginning January 1st, 2022. That's fairly rare. It seems like every year we have new telehealth services in those categories. But outside of that, we had a big change to the categorization of telehealth effective January 1st, 2021, where last year Medicare created a new Category 3 group of telehealth services. We also had services that were added last year on an interim basis to the covered telehealth list. And there is a distinction there, and the distinction becomes really important as the public health emergency comes to an end in determining coverage dates. So we have kind of two buckets here of temporarily covered telehealth services through the public health emergency. Category 3 services, it's kind of a temporary holding bucket for covered telehealth services that ultimately will need to meet criteria under Category 1 because they're similar to other permanently covered telehealth services, or Category 2, they're dissimilar to other covered telehealth services, but there's proven clinical benefit. So they're going to sit in this Category 3, this kind of temporary holding bucket as covered telehealth services until they can be added on one of those two bases. So in this Category 3, Medicare determined, they did a clinical assessment to identify which of the temporarily covered telehealth services Medicare could foresee a reasonable potential likelihood of clinical benefit. But there hasn't necessarily been enough data collected yet to demonstrate that benefit and add them as Category 1 or 2 services yet. On the other hand, there are interim telehealth services that are covered right now when delivered via telehealth, but they are not Category 3 telehealth services. And that distinction becomes very important in this proposed rule. There are 106 codes covered as telehealth right now on an interim basis, not a Category 3 basis, and coverage for those services will end when the public health emergency ends. However, Medicare is seeking comment on whether those interim telehealth services should be added into the Category 3 bucket. That becomes important because those telehealth services that are in the Category 3 bucket, they're temporarily covered while we collect data, while we look at their clinical efficacy, and eventually would have to be added as permanent services under Category 1 or Category 2. But if they make it into the Category 3 bucket, there's likely clinical benefit, and Medicare is proposing to extend coverage of everything in Category 3 through December 31st of 2023. So it gives us considerably more time to provide those services via telehealth than if they are interim telehealth services. So in the next couple of slides, I'll show you a list of services that were requested to be added as permanent Category 1 or Category 2 telehealth services, but Medicare found that none of those requests that were received by the deadline met criteria for Category 1 or Category 2, so Medicare is not proposing to add any of the following services as telehealth services for next year. Medicare's been taking a close look at claims data for audio-only telephone evaluation and management services that were added as covered telehealth services as part of the public health emergency. And Medicare has found that audio-only E&M visits have been some of the most commonly performed telehealth services during the emergency, and that most of the patients receiving audio-only services were receiving them for treatment of a mental health condition. And Medicare also kind of looked at trends over time that, based on data when the public health emergency first started, there was a big spike in the use of telehealth for many services around March and April last year, and then it kind of diminished over the following months. However, Medicare found that claims data for mental health services that were added to the telehealth list had actually a steady trend from April 2020 and afterwards. So Medicare is considering permanently expanding coverage for audio-only services to certain mental health visits. Under the Support Act that's already in place, a patient's home can be an eligible originating site for certain substance use disorder services or for the treatment of co-occurring mental health disorders when delivered via telehealth. And Medicare also does not limit coverage of those substance use disorder services to patients in rural areas. The recent Consolidated Appropriations Act would expand on telehealth coverage for mental health conditions, allowing the patient's home to serve as an originating site for the diagnosis, evaluation, or treatment of a mental health disorder for services even after the public health emergency. There would be no geographic restriction to rural areas for these services delivered via telehealth, even after the public health emergency ends. And this is different than coverage under the existing Support Act, because these services delivered via telehealth would not be limited to patients with substance use disorder, would not be limited to patients with co-occurring mental health conditions. To provide the services, Medicare proposes that there be an in-person visit within the previous 6 months of the first telehealth visit and then every 6 months afterwards. But again, that in-person requirement refers only to telehealth services used for the diagnosis, evaluation, or treatment of mental health disorders when the patient is at home and the patient is outside a rural area, and in patients without substance use disorder or co-occurring mental health disorders that would otherwise already be covered under the Support Act. May need to pause that and play that back because it's very technical and very complicated. If a patient has substance use disorder or a co-occurring mental health disorder, then those in-person visit requirements do not apply to the telehealth services that are being provided. Look in the final rule, watch for coding guidance. Medicare is considering requiring a modifier on those telehealth visits where the patient's at home, where the patient's outside a rural area, and where the service is for the diagnosis, evaluation, or treatment of a mental health disorder delivered via telehealth that is not otherwise covered by the Support Act. And you would have to apply that modifier to trigger for Medicare that the in-person service requirements apply. And then, of course, Medicare could use claims data to evaluate whether there had been an appropriate in-person visit. And speaking of the in-person visit requirement, Medicare is considering whether that in-person service must be provided by the practitioner delivering the telehealth service or whether it could be delivered by another practitioner. So Medicare notes that in the Consolidated Appropriations Act, the language says that the physician or practitioner furnishing the in-person non-telehealth service must be the same person as the practitioner furnishing the telehealth service. But Medicare recognizes that in many of its billing rules, it treats providers of the same specialty in the same group practice as the same individual for billing purposes and is considering whether they would allow other practitioners in the same group practice to provide those inpatient services. Also recognizing the importance of ensuring access to mental health telehealth services to patients who are unable to see the same practitioner who provided that in-person service because of unavailability or other reasons. Medicare's seeking comment on an alternative policy to also allow that prerequisite in-person non-telehealth service for certain mental health telehealth visits to be furnished by a practitioner in the same specialty, in the same group practice, only when the provider who renders the telehealth service is unavailable or when the two professionals are practicing as a team. And I read that request for comment and Medicare's expectation to apply a modifier in these certain situations, and it just sounds like a logistical nightmare to me. So if these are services that you're providing, take a look at what the proposed rule is suggesting and what Medicare is seeking comment on, and I encourage you to submit a comment on how that would logistically work or not work. Now, the method of delivery, this could be an audio-only telehealth service, but the ability to use audio only is limited to patients with mental health conditions who are at home, and then Medicare is also considering frequency limits for audio-only services. And again, that's limited to patients with mental health conditions. Now, I want to emphasize too that nothing requires that these services for the evaluation, diagnosis, and treatment of mental health services via telehealth be provided by audio only. They can still be delivered by audio-visual, real-way two-way communications. There are some additional potential restrictions and caveats if those services eligible for audio only are in fact delivered via audio only. Medicare also proposes that in order to deliver them with audio only and not audio visual is that the patient is unable to use, does not want to use, or does not have access to two-way audio visual technology. When I read that restriction, the first thing I think about is documentation requirements, right? How will the record reflect, one, that the service was delivered audio only, and two, that the requirement that the patient was unable to use, didn't want to use, or didn't have access to audiovisual technology was met to enable coverage of that service being provided by phone call only. When you're delivering the service by audio only, for the diagnosis, evaluation, or treatment of mental health conditions to a patient in their home. And again, this is a Medicare rule, so it would also be limited just to Medicare at this time, is that the patient would have to be an established patient also. Some things to look for in the final rule are more documentation requirements. Medicare expressly said they're considering what they would expect or require to be documented in the medical record. Medicare is also considering whether those audio-only services for mental health conditions may need to be limited to different levels of service. That stands out to me, and I kind of put a red flag on that because time is such an important driver of the level of service now that level of service does not necessarily equate to complexity in all instances. And so putting a limit on the level of service could also limit how long you could provide that service. And I also think about individuals who are eligible for Medicare and sometimes can be chatty, and services may take longer than expected because of the interaction between the patient and the provider. So that's something I'm particularly interested in, whether they're going to put limits on the level of service that you can report for audio only visits for mental health services. Medicare is also considering whether they should exclude coverage of services delivered via audio only if a psychotherapy add-on code is used in conjunction with the evaluation and management service, and or whether Medicare should exclude coverage via phone call or audio only if a crisis code is reported in conjunction with the evaluation and management service. The other thing to keep in mind is that while the patient has to be unable to, does not want to, or does not have access to audiovisual technology, the provider still must have the capacity to do audiovisual communication with the patient for these services to be covered. Medicare is also considering a modifier to identify an audio-only service in these diagnosis, evaluation, and treatment of mental health disorders, and that use of that modifier would certify compliance with all of these rules and requirements. So that's going to be really important to watch for as well, and for the coders and the billers to understand the significance of that modifier. It's not one we merely append just to get paid, but it is an express certification that we're meeting requirement. Prior to the public health emergency, Medicare had already created a communication technology-based service that Medicare was paying. This was the virtual check-in by a physician or other qualified healthcare professional, not related to an E&M service in the previous 7 days, not leading to an evaluation and management service within the next 24 hours or whatever the soonest available appointment is. But the previous code was limited to up to 10 minutes of medical discussion. And as part of the public health emergency, Medicare temporarily, on an interim basis, created this extended CTBS service code that represents 11 to 20 minutes of medical discussion. And in this proposed rule, Medicare would make that a permanently covered service. If you report evaluation and management services, you're probably familiar with the Medicare Claims Processing Manual. Chapter 12 is where Medicare has housed many rules, requirements, and restrictions on evaluation and management services in this provider manual for years and years. And more recently, there has been a policy initiative and a movement towards good policy interpretation in compliance with the Administrative Procedures Act, which typically requires going through the rulemaking process, or the agencies go through the rulemaking process, which is the proposed rule, a public comment period, and then a final rule. And the Department of Health and Human Services issued some good guidance regulations recently, giving more information on their expectations and how they would ask that an agency kind of redo their policy making when they haven't gone through the appropriate procedures. So the Department of Health and Human Services petitioned CMS to withdraw various sections of the Medicare Claims Processing Manual involving evaluation and management services. In particular, important for this proposed rule, provisions related to split and shared visits and critical care services. And the withdrawal of that guidance was effective May 9th of 2001. So those rules are not in the Medicare manuals right now. And instead, Medicare is now going through the rulemaking process, proposed rule, public comment, and final rule. In the interim, I think it's important for everyone to keep their eyes and ears open for medical reviews where the reviewer may make comments denying or decreasing levels of service, citing to split shared rules or citing to the critical care rules. And although Medicare has been instructed or has advised it would not review records for compliance with those requirements, we have to kind of hold the actual reviewers accountable to that and make sure that they are not applying these rules when they shouldn't be. I also think this is important to keep your eyes and ears open for Medicare reviews retroactively, even before these were taken out of the manuals in May 9th, 2021, when the reviewer is citing to split shared rules and citing to critical care rules from the manuals. I think providers may have a basis to fight back on any of those denials or reduced payments because of this petition from the Department of Health and Human Services that maybe those rules in the manuals had not gone in place using the appropriate Administrative Procedures Act and rulemaking process, and therefore were ineffective or invalidated. So when I say a split or shared visit, that refers to an evaluation and management service that is performed or split or shared between a physician and a non-physician practitioner who are in the same group. And this is kind of the progression of how all of these rules looked. First, the rules for split or shared visits were entirely based on policy within Medicare's Internet-only manual, the Claims Processing Manual 104, Chapter 12. And some conditions that Medicare placed on split or shared visits was that the patient had to be an established patient in order to provide a split or shared service. The physician must perform a substantive portion of the visit, and I put that in quotations because that's kind of a gray area that was always left room for interpretation or dispute during medical review. And if those requirements were met, then the service can be reported under the physician's name and number and paid at 100% of the fee schedule rather than at the reduced 85% rate of a non-physician practitioner. The rules for incident to services only apply to institutional settings, okay? Because incident to rules apply to non-institutional settings. Let me make sure I said that correctly. Split shared rules applied to institutional settings, hospitals, for example, where incident to rules that similarly provide a mechanism for services delivered by non-physician practitioners to be billed under a physician name or number, those apply to non-institutional settings like the physician office or clinic. So that was what was in place previously. Those rules, those conditions were withdrawn effective May 9th, 2021. Because as part of the Good Guidance Regulations, the Department of Health and Human Services petitioned CMS to remove those provisions and to instead go through the rulemaking process and put those rules into regulations. And that's what we're seeing in this proposed rule. So there was a petition January 19th. There's a link here if you want to view CMS's response. The Medicare's transmittal instructing contractors not to apply those rules, and then now we have the proposed rule. But we have some changes in this proposed rule compared to what was previously in the Internet-only manual. Now, the rules for split shared services have been in place for a long time, so this may represent a significant change for your internal reviewers as well as what we need to make sure any external reviewers would be applying if these proposed rules go into effect. So some of the changes that Medicare suggests that it will put into the regulations and ultimately reintroduce these new rules into the manuals is that split and shared services could be provided to either new or established patients versus just established patients as was in the rules previously. Which also means if we're talking about a facility setting, it could be to someone who both an initial and a subsequent visit. Medicare would also allow split or shared services to be provided in the skilled nursing facility or nursing facility setting, where that was not previously a permitted institutional setting when split and shared visits could be provided. They now would also be allowed for critical care, and I'll talk about that in more detail in just a few minutes. And then Medicare proposes that in quotes, that substantive portion of the visit that has to be provided by the physician in order to bill the split or shared visit under the physician's name and receive 100% of the allowable of the fee schedule amount. It means that the physician has to perform more than 50% of the visit in terms of time. So that immediately sends kind of a red flag up in my mind that each provider's time needs to be documented so that we know which one spent greater than 50% of the time. One of the questions that raises for me is that if we have maybe 3 providers involved, none of them potentially may provide more than 50% of the time, right? We could have a third, a third, a third. And under that definition, there would be no physician providing a substantive portion of the visit, which would limit us to reporting the visit under a non-physician practitioner's name and number. Medicare also clarifies that prolonged services could be split or shared services also. So this is how Medicare would define a split or shared visit in the regulations. It would be an E&M visit in the facility setting that's performed in part by both a physician and a non-physician practitioner who are in the same group in accordance with applicable laws and regulations. So there's 2 important pieces there. We know the definition of a non-physician practitioner. Facility setting, Medicare would define as an institutional setting in which payment for services and supplies furnished incident to a physician or practitioner's professional services is prohibited under regulations at 41026. In other words, it would be a hospital setting, it would be a skilled nursing facility setting, potentially even emergency department visits as well. So some other provisions that Medicare would have with respect to split and shared service, that the level of service that you report could still be selected based on medical decision making, or it could be based on time. So the substantive portion piece only determines who bills the service and not the code that you report. Medicare clarifies that only distinct time can count towards the level of service, right? So if we have physician and non-physician practitioner in the room at the same time for the patient, we cannot combine that time when they're in the room together to select a level of service. That's also raising some flags for me on documentation, that merely asking each provider to document their total time is insufficient. We would also need them to know that they have to carve out or specifically identify concurrent time with the patient. Medicare defers to the CPT's descriptions of the types of activities that can count towards a provider's time in selecting a level of service. And Medicare questions or asks for comment or is considering whether to create a separate list of activities that can count towards the time specific to emergency department services. I think this is the 3rd time now that I've mentioned Medicare's considering a modifier. So my gosh, modifiers are going to be huge in this proposed or in the final rule to look for. We may have several modifiers, and the modifier in this instance would be used to identify when a service that we're reporting under a physician's name and number was a split or shared visit. I mentioned one of the changes that Medicare is proposing for split and shared services is that critical care could now be provided and reported as a split or shared service also, where previously that initial critical care time for 99291 had to be performed and the minimum time requirement had to be met by a single individual, and it could not be provided as a split or shared service. So that's one of the changes. By and large, Medicare is adopting CPT rules with respect to critical care, including the definition, the list of services that would bundle into the payment for critical care codes 99291, 99292. So critical care is the direct delivery by a physician or other qualified healthcare professional for a critically ill or injured individual where there is acute impairment of one or more vital organ systems such that there is probability of imminent or life-threatening deterioration in the patient's condition. It involves high complexity decision-making to treat single or multiple vital organ system failure and or to prevent further life-threatening deterioration of the patient's condition. Some changes that we see in this proposed rule with respect to critical care over what we previously had in Medicare's manuals is that Medicare would allow critical care to be provided as a concurrent care service regardless of group affiliation. So concurrent care rules means that multiple providers can render evaluation and management services to the same patient on the same day as long as it's medically necessary. And that can happen within the same group or outside the same group. What Medicare often looks for is whether different diagnoses are being treated. So we may have pulmonology and gastroenterology and nephrology seeing the patient on the same day. It's not necessary that there are different diagnoses, but that can often be a good indicator. So Medicare clarifies critical care could be provided as a concurrent care service where more than one physician or non-physician practitioner furnished critical care to the same patient on the same day, regardless of their group affiliation. All providers in the same group, the same day, providing critical care to the same patient could combine their time to determine 99291 and how many additional units of 99292 are supported. So then when we have multiple providers in the same group on the same day providing critical care to the same patient, where we're combining their time to report, we then have to decide who gets to report those critical care services. And similar to split or shared visits, Medicare is suggesting that the provider reporting more than 50% of the time, the collective time, would bill the critical care services to the patient that day. So within a single group, 99291 would only be reported once per patient, per day, per group. If we have providers from multiple group practices delivering critical care, we may see, 99291 reported more than once per day per patient, but they would have to be from separate group practices. This also is something I think I expect to see some comments on, and my guess would be that Medicare may revise this instead of more than 50% of the time to say the provider who bills the greatest amount of time during the day, because within a group practice, we may have 3 specialists providing critical care to the patient on one day, and for similar reasons, none of them then may have more than 50% of the total time of critical care to that patient that day. So be looking for comments. If you have your own comments, make sure you submit those to Medicare on that proposal. And that would determine which of those provider bills for the critical care service. And because it could be provided as a split or shared service, if those professionals include non-physician practitioners, only if a physician is the provider who billed or provided more than 50% of the time, a substantive portion of that visit, could the physician be the one to report the critical care for that patient on that day. Medicare historically has allowed payment for other evaluation and management services to the same patient on the same day, but under this proposed rule, Medicare would no longer allow other E&M visits for the same patient on the same day that critical care was provided among providers in the same specialty and the same group practice. Medicare also proposes that critical care would bundle into the payment, the post-op for procedures with 10 and 90-day global periods. So unless it was a distinct and separate service where we could report a modifier 24, critical care would otherwise be part of the global post-op period. So some other provisions that we see with critical care. Medicare would not necessarily require documentation of start and stop times, but we still would need total times from each provider. And Medicare expects to see sufficient documentation that would allow a reviewer to determine the role that each professional played in the critical care to that patient on that day. We also have a few proposals with respect to teaching physicians services and how the level of service and the physician presence requirement are met and addressed and billed. So under the proposed rule, Medicare says that if an evaluation and management service is selected based on time, then only the teaching physician's time can be used to determine the level of service. And the rationale was that residents providing a portion of that service may inherently take longer to deliver a service of the same complexity because they're still learning. And so if we're using time versus medical decision making, only the teaching physician's time can be used to select the level of service. Medicare also says that the teaching physician's presence via audiovisual real-time communication during the service, which is allowed during the public health emergency, can count towards that time that is used to select the level of service. Now remember, in the manuals, there's a rule that in order to bill the service under the teaching physician's name and number, the teaching physician has to provide a key or critical portion of the service. So Medicare says that in the case of evaluation and management services, the teaching physician has to be present during the portion of the service that determines the level of service billed. So again, if we're selecting that visit based on time, we can only use the teaching physician's time. The teaching physician has to be present during that time that is determining the level of service billed. There are some changes to physician assistants in this proposed rule as well. Right now, there are regulations, or actually it was a statutory restriction that physician assistants services could only be billed by and paid to their employer. A physician assistant could not directly and independently bill Medicare and be paid for their services. So that statutory restriction was removed under the Consolidation Appropriations Act just recently. And Medicare is putting into its regulations recognizing that restriction is no longer in place. So regulations requiring that payment for physician assistant services go to the employer and not to the physician assistant directly are no longer in place. This puts physician assistants in the same position from a billing perspective as nurse practitioners and clinical nurse specialists, where they can still reassign their benefits to employers, but they don't have to. Other impacts that this would have is that group practices consisting entirely of physician assistants can now bill and be paid for physician assistant services. Previously, a group practice consisting entirely of physician assistants was not a qualified employer who could bill for and be paid for PA services. Physician assistants can still reassign their payment benefit Or they could bill and be paid directly for their services without an employer or a group practice. However, the payment rule on what they get paid, the requirements for supervision, that has not changed. So now I'll look briefly at some guidance that Medicare is giving on when and how we determine that services for therapy for PT and OT should be billed under the therapist or instead under the therapy assistant. There are rules already in place that allow therapy assistance services to be paid at a reduced rate, similar to how nurse practitioners and physician assistant services are paid just at a reduced rate below what would be allowed for the licensed physician that they're collaborating with or supervised by. Medicare gave some guidance in the proposed rule on what I feel like are some pretty hyper-technical formulas to determine when and how we bill for the therapy assistance services under their name and number versus their supervising therapist. I encourage you, if you're providing therapy services, to go into the proposed rule and look at those formulas. You may already know that determining the number of units of therapeutic activities and therapeutic modalities in 15-minute increments, it can already get pretty complicated. And this, to me, only adds to that complexity. So at a very high level overview, if the therapist, the PT or the OT, is exclusively providing a visit to the patient, that's easy. We're going to bill under the therapist's name and number. They'll be paid at the full fee schedule rate, and then we'll add therapy plan of care modifiers to those services. Now let's switch kind of to the other side of the spectrum. When it is the therapy assistant exclusively providing the visit, the therapy assistant will bill for the service. We'll still report the therapy plan of care modifiers. It will be paid, those services will be paid at a reduced rate of 85% of the fee schedule that would have been paid if it was delivered by the therapist. And then we add modifiers CQ or CO, and that just indicates that it was a service provided in whole or in part by a physical therapy assistant or an occupational therapy assistant. Then we get into kind of the more complicated gray areas because the reduced rate applies to services provided in whole by a therapy assistant. So that's kind of that middle column, or in part by therapy assistants. So Medicare now is giving us guidance on what it means to be in part by therapy assistants. Okay, so this is on the far right column then. The question is whether the therapy assistant provided 10% or more of the services. That is kind of the threshold that will take us into the middle column when Medicare will only pay for 85% of the fee schedule amount. And that 10% threshold is based on the amount of time. Most of the therapy codes are time-based codes, but not all of them. This 10% or more rule applies regardless of whether the code being reported is a time-based code or an untimed code. So that's immediately sending a flag up in my mind that even for untimed visits, if a therapy assistant is going to be involved, then both the therapist and the therapy assistant still need to be documenting their time so that we can determine whether that 10% threshold is met and justify reporting a service either under the therapist's name or number or identifying when it needs to be reported by the therapy assistant. The other thing that we need to know about that time is that it applies to every 15-minute unit, not the totality of services. So for every unit we're reporting, we need to be able to identify what role the therapist played, what role the therapy assistant played, and whether the therapy assistant provided 10% or more of the service based on time. Now, if the assistant is in the room concurrently with the therapist for the entire service, just assisting, but the therapy is present for the entire service, then the service is going to be reported under the therapist's name and number. Moving right along to Medicare's policy to finally close the gap on colorectal cancer screening services so that patients will not have financial responsibility when they receive a screening service, but lo and behold, something is found and the provider intervenes for therapeutic treatment. So a little bit of background, Medicare has paid for screening, sigmoidoscopy, and colonoscopies for a long time. Whenever the patient was presenting with no signs, no symptoms, other criteria were met, Medicare paid the surgeon and the facility fee for the screening procedure at 100%, no deductible, no coinsurance. But there were some hiccups. There were some maybe oversights or kind of loopholes that could still cause the patient to incur financial responsibility for those services. One of those was that when there's a separate anesthesia charge, Medicare had not expressly included that as coverage at 100%. So the patient may incur financial responsibility for anesthesia, something they didn't necessarily want or anticipate, and that was problematic. Another issue was that often during those procedures, the provider might find polyps or other issues and may take a biopsy, may do cell washings, may perform other therapeutic procedures in the course of the sigmoidoscopy or colonoscopy. And that would cause the procedure code to change from a screening colonoscopy to a surgical endoscopy procedure. And when the procedure code changed, even though there was a screening diagnosis code listed as the first listed diagnosis, Medicare wasn't paying for those as a truly preventive service. So there have been incremental changes over time to address some of those issues. Anesthesia was recently added in the last couple of years, where Medicare would cover the anesthesia service for a screening procedure at 100%. Under the Consolidated Appropriations Act, colorectal cancer, sigmoidoscopy, and colonoscopy screening procedures will eventually be covered at 100% regardless of the code that is used. And that's because the most recent development is that when a screening procedure turns diagnostic or therapeutic, Medicare issued guidance that I believe it's the deductible would be waived, but coinsurance continues to apply, but only if they find something and they do something about it. And that's the whole point of the screening procedure, right? The early detection. So patients are frustrated that they end up with an out-of-pocket cost for what they thought was a covered preventive service. So over the next 9 years, Medicare is going to incrementally address that issue so that the current coinsurance rate will increase from 80% covered by Medicare, 20% to the patient, effective January 1st, 2022, until 2030, when Medicare finally will cover the deductible and the entire coinsurance amount for screening procedures, regardless of whether something is found and regardless of the procedure code that's eventually used to describe the service. We also have several policy changes for rural health clinics and FQHCs that represent increased billing and reimbursement opportunities, increased flexibilities for these provider types. One of those changes is that Medicare proposes to modify the longstanding policy that rural health clinics and FQHCs are prohibited from billing for their providers' services in the role of a hospice attending physician. And instead of requiring that the providers be working outside their capacity as an RHC or FQHC provider and separately bill for any professional fees for hospice attending physician services, under this proposal, the RHC or the FQHC could directly bill for and be paid for their provider's hospice attending physician services. Now, RHCs and FQHCs can already bill for transitional care management services and chronic care management services separate from their PPS or their all-inclusive rates. There have been modifications to policies for fee-for-service providers that allow fee-for-service providers to report transitional care management and chronic care management if the time frame or the date range of those services overlaps. And that's been allowed since 2020, but Medicare did not make that same change for RHCs and FQHCs. And under this proposal, Medicare would put them in parity with their fee-for-service counterparts and allow RHCs and FQHCs to bill for transitional and chronic care management provided to a patient within the same time frame. That policy includes code G0511, general care management for RHCs and FQHCs, as well as G0512, which is a psychiatric chronic care management code specific to RHCs and FQHCs. We've seen a lot of changes to the definition of direct supervision as a result of the public health emergency. Before COVID, the rule for direct supervision in the clinic setting, for example, is that the provider and the practitioner or professional who is delivering the service have to be, I should say, the provider has to be in the office suite and immediately available to provide assistance in the same location where the service is being provided. We had to change to that because a lot of telehealth services began to be provided incident to the physician or MPP's professional services, right? So we could do something like a blood pressure check or an INR visit from a nurse to a patient under incident to rules. But when we're doing that via telehealth, the concept of the physician being in the office suite and immediately available doesn't really apply the same way. So Medicare said that direct supervision could be met through virtual presence, meaning that the provider was immediately available to engage in that service via interactive technology. That real-time presence throughout the entire service is not required, just like it would not have been required via an in-person face-to-face visit. That interactive technology through which the provider had to be immediately available to engage and intervene included interactive, audio-visual, real-time communications, not simply audio-only services. So that flexibility would, as we stand right now, end at the end of the calendar year when the public health emergency ends. Medicare is seeking comment on whether it should extend that concept of virtual presence as a way to meet the direct supervision requirement and or to make that supervision rule a permanent rule. Medicare wants to know whether if it extended coverage of virtual presence as a way to meet direct supervision, whether that should be allowed for all services that can be provided under direct supervision, or whether only a subset of those services should be allowed to be provided through virtual presence as direct supervision. And a modifier. I think that's the fourth or fifth time that Medicare is proposing a modifier to identify when the supervision was met through virtual presence versus just your traditional in the office suite immediately available type of direct supervision. So keep your eye out for those rules as well. Submit your comments on those elements, whether to extend, make permanent all services or a subset of services if you have them. Well, it's hard to consolidate 1,700 pages, but I've done my best to give you kind of a 15,000-foot overview, a high-level overview of what's in the proposed rule. If you have any questions or need more information on the specifics of any of these provisions, feel free to pull up the proposed rule or shoot me an email, let me know, and I'll be happy to get more information for you.